Summary of IgA nephropathy for pediatric specialists. Overview: IgA nephropathy, Buerger's disease, the most prevalent primary glomerulonephritis globally, characterized by the deposition of IgA immune complexes in the glomerular mesangium, leading to inflammation and varying degrees of kidney damage. Epidemiology: most commonly affects individuals in their second to third decades of life, with a male predominance, 2:1 ratio, and higher incidence in the Asian population. Pathophysiology: the etiology involves the production of abnormal IgA antibodies, often triggered by mucosal infections. These IgA immune complexes deposit in the renal mesangium, causing inflammation and glomerular injury. Clinical features: variable presentation ranging from asymptomatic microhematuria to acute nephritic syndrome, often exacerbated by respiratory or gastrointestinal infections. Approximately 50% of cases progress to end-stage renal disease over 20 to 25 years. Diagnostics: urinalysis, persistent microhematuria, sometimes with minor proteinuria, episodic gross hematuria post-infection in some cases. Serum IgA levels, elevated in about 50% of patients. Renal biopsy, indicated in severe progressive cases showing mesangial proliferation and IgA deposits. Complement levels, typically normal. Differential diagnoses include post-streptococcal glomerulonephritis, low complement levels, lupus nephritis, and membranoproliferative glomerulonephritis. Treatment: asymptomatic or mild cases, regular monitoring with intervention for disease progression. Proteinuria, hypertension. Initiate ACE inhibitors, e.g. lisinopril, or angiotensin II receptor blockers, ARBs, e.g. losartan, to reduce proteinuria and manage hypertension. Severe progressive disease, immunosuppressants, corticosteroids, e.g. prednisone, as the mainstay, with the addition of cytotoxic agents like cyclophosphamide or azathioprine in resistant cases. Supportive management includes blood pressure control, dietary protein restriction, and lipid management. Key points for specialist pediatric doctors: early detection and proactive management are crucial to prevent or delay progression to end-stage renal disease. Treatment should be individualized based on disease severity, with a focus on controlling hypertension and proteinuria to slow renal damage. Multidisciplinary care, including nephrology, nutrition, and potentially rheumatology, is vital for comprehensive management and patient support. Clinical case: IgA nephropathy in a pediatric patient. Age: 14 years. Gender: male. Presenting complaint: gross hematuria following an upper respiratory tract infection. History of present illness: the patient presented with painless gross hematuria 2 days after recovering from an upper respiratory tract infection. There was no preceding history of trauma, strenuous exercise, or medication use known to cause hematuria. The patient also reported mild flank pain but denied any fever, rash, joint pain, or recent travel. Medical history: unremarkable, with no previous episodes of hematuria or significant illnesses. Family history: non-contributory, no known renal diseases or autoimmune disorders. Social history: the patient is a middle school student, active in sports, with no history of substance use. Physical examination: general, well-nourished, well-developed male in no acute distress. Vital signs: BP 128, 82 mm Hg, HR 76 BNR 16 min, temp 98.6 Gisfang Faris 37 degrees. Cardiovascular exam: regular rhythm, no murmurs, rubs, or gallops. Abdominal exam: soft, non-tender, no masses, normal bowel sounds, no hepatosplenomegaly. Skin exam: no rashes or petechiae. Extremities: no edema. Diagnostic tests: urinalysis, gross hematuria, 1+ protein, no casts, no signs of infection. Blood work: normal renal function, elevated serum IgA levels, C3 and C4 within normal ranges. Renal ultrasound: normal size kidneys with no signs of obstruction or masses. Renal biopsy, indicated due to persistent hematuria and proteinuria, revealing mesangial proliferation and IgA deposition, confirming the diagnosis of IgA nephropathy. Management. Initial approach: the patient was advised to maintain adequate hydration and avoid nephrotoxic drugs. Given the mild symptoms, a conservative approach was initially adopted. Medication: as the proteinuria was above 1 g per day and persistent, an ACE inhibitor, lisinopril, was started to reduce proteinuria and protect renal function. Follow-up, regular monitoring of renal function, blood pressure, and proteinuria was planned. Discussion points. The importance of considering IgA nephropathy in pediatric patients presenting with gross hematuria following an upper respiratory infection. The role of renal biopsy in confirming the diagnosis of IgA nephropathy, especially when clinical and laboratory findings suggest a glomerular source of hematuria. The use of ACE inhibitors as a cornerstone in managing proteinuria in IgA nephropathy to slow the progression of renal disease. The need for long-term follow-up to monitor disease progression, response to therapy, and the development of potential complications such as hypertension and chronic kidney disease. Summary of Alport syndrome for pediatric specialists. Overview. Alport syndrome, a genetic condition characterized by a triad of progressive glomerulonephritis, sensorineural hearing loss, and ocular abnormalities due to mutations affecting type 4 collagen. Epidemiology. It's a rare hereditary nephritis with variable age of onset and symptom severity, often more severe in males due to its common X-linked inheritance pattern. And in pathophysiology, mutations in the genes encoding type 4 collagen lead to structural abnormalities in the basement membranes of the kidneys, cochlea, and eyes, resulting in the clinical manifestations of Alport syndrome. Clinical features. Early stage often presents with intermittent gross hematuria in infancy, which may initially be the only symptom. Progression leads to features of nephritic syndrome and chronic kidney disease, typically progressing to ESRD between 16 to 35 years. Extrarenal manifestations include sensorineural hearing loss and ocular abnormalities like anterior lenticonus and paramacular flex. Diagnostics, urinalysis shows hematuria and minor proteinuria, best initial test. Renal function tests, elevated BUN and creatinine levels indicate renal impairment. Kidney biopsy. Key findings include mesangial proliferation, sclerosis, and the characteristic basket weave appearance on electron microscopy. Skin biopsy, absence of type 4 collagen alpha 5 chains. Molecular genetic testing confirms diagnosis and subtype. Audiometry and ophthalmic evaluation to assess for hearing loss and ocular involvement. Treatment, renal function monitoring, essential for early detection of progression to chronic kidney disease. Proteinuria management, ACE inhibitors, e.g. lisinopril, or ARBs, e.g. losartan, are first line to reduce proteinuria and slow renal disease progression. Kidney transplantation, the definitive treatment for ESRD. However, post-transplant monitoring is crucial due to the risk of developing de novo antiglomerular basement membrane disease. Supportive care includes management of hearing loss with hearing aids and surgical correction for ocular anomalies. Key points for specialist pediatric doctors. Early recognition and multidisciplinary management of Alport syndrome are crucial to mitigate renal progression and address hearing and visual impairments. Genetic counseling is essential for affected families to understand inheritance patterns, recurrence risks, and implications for future pregnancies. Regular follow-up with nephrology, audiology, and ophthalmology is necessary to monitor disease progression and intervene appropriately. Clinical case, pediatric Alport syndrome. Patient information, age, 8 years old, gender, male, presenting complaint, recurrent episodes of blood in the urine and recent difficulty hearing in class. History of present illness. The patient, an 8-year-old boy, presents with a 2-year history of intermittent gross hematuria, often following minor upper respiratory infections. Recently, his school teacher noticed he has difficulty hearing, especially in a noisy environment. Medical history. No significant past medical history. No previous hospitalizations or surgeries. Family history. The patient's maternal uncle underwent kidney transplantation in his late 20s, diagnosed with an unspecified genetic kidney problem. Social history. The patient is in the 3rd grade, enjoys playing soccer, and lives with his parents and younger sister. Physical examination. General, alert, cooperative, and well-nourished male child. Vital signs: BP 110/70 millimeter Hg, HR 78 BPM, RR 16 min, temp 98.6 degrees C. Cardiovascular exam, regular rhythm, no murmurs. Abdominal exam, soft, non-tender, no organomegaly. Skin exam, no rashes or petechiae. Audiological exam, decreased response to high-frequency tones. Diagnostic tests: urinalysis, gross hematuria, 1+ protein, no casts or signs of infection. Renal function, within normal limits. Hearing test, audiometry, confirmed bilateral high-frequency sensorineural hearing loss. Ophthalmologic examination, normal fundoscopy, no lens abnormalities. Kidney ultrasound, normal-sized kidneys with no structural abnormalities. Genetic testing revealed a mutation in the COL4A5 gene, confirming the diagnosis of X-linked Alport syndrome. Management, immediate actions, education about the nature of the disease, and discussion about the importance of regular nephrology follow-up. Medication, initiated on an ACE inhibitor, lisinopril, to reduce proteinuria and potential progression of kidney disease. Hearing support, referral to an audiologist for hearing aids and strategies to cope with hearing loss in academic settings. Follow-up and long-term management, nephrology, regular monitoring of renal function and proteinuria with an emphasis on early detection of renal disease progression. Audiology, regular hearing assessments and adjustments to hearing aid settings as needed. Genetic counseling, provided to the family to discuss inheritance patterns, testing for the patient's sister, and implications for future family planning. HSP discussion points: the importance of considering Alport syndrome in children presenting with recurrent hematuria and sensorineural hearing loss. The role of genetic testing in confirming the diagnosis and guiding family counseling. The need for a multidisciplinary approach, including nephrology, audiology, and genetics, to manage the various aspects of Alport syndrome effectively. Summary of IgA vasculitis, IgAV for pediatric specialists. Overview. IgA vasculitis, IgAV, previously known as Henoch-Schönlein purpura, is a small vessel vasculitis characterized by palpable purpura, arthritis, arthralgia, abdominal pain, and renal involvement. Epidemiology. Predominantly affects children, with the peak incidence around 6 years of age. It's more common in males. Pathophysiology involves IgA immune complex deposition in small vessels, leading to vasculitis. The exact trigger is often unclear, but may be related to preceding infections or a genetic predisposition. Clinical features: dermatological, palpable purpura, typically on the lower extremities and buttocks. Musculoskeletal, arthritis or arthralgia, often affecting the knees and ankles. Gastrointestinal, abdominal pain, which can be colicky in nature, potentially leading to complications like intussusception. Renal, IgAV nephritis presents with hematuria and proteinuria, can progress to more severe renal disease. Diagnostics. Clinical diagnosis supported by urinalysis, hematuria and proteinuria. Skin biopsy shows leukocytoclastic vasculitis with predominant IgA deposition. Renal function tests assess for nephritis. Abdominal ultrasound in cases of significant abdominal pain to rule out intussusception. Treatment: supportive care, hydration, pain management with NSAIDs or acetaminophen. Systemic glucocorticoids. Prednisone is commonly used for severe cases, particularly with significant renal or gastrointestinal involvement. Immunosuppressive therapy. In cases of severe or refractory IgAV nephritis, medications like cyclophosphamide or mycophenolate mofetil may be considered. Key management points: early identification. Recognize the typical clinical presentation to initiate timely supportive care and avoid unnecessary investigations. Monitoring for renal involvement. Regular urinalysis and blood pressure monitoring are crucial for early detection of IgAV nephritis. Multidisciplinary approach. Collaboration with dermatology, nephrology, and possibly gastroenterology is often necessary for comprehensive management. Patient and family education. Inform about the disease course, potential for relapse, and signs of renal involvement. Follow-up. Essential to monitor for long-term renal complications, even in patients with mild initial presentation. Serial urinalysis and blood pressure checks are recommended. This concise summary is designed to provide a clear, actionable overview of IgA vasculitis for pediatric specialists, incorporating specific diagnostic findings and treatment options to guide patient care. Clinical case, pediatric IgA vasculitis. Patient information, age, 7 years old, gender, male, presenting complaint, rash on the legs and abdominal pain, history of present illness. The patient, a previously healthy 7-year-old boy, presents with a 3-day history of a painful rash on his lower extremities and intermittent abdominal pain. The rash started as red spots that have become raised and palpable. The abdominal pain is colicky in nature, worsening post-meals. The mother reports a recent upper respiratory tract infection 2 weeks ago, which resolved without intervention. Medical history, unremarkable, up to date on vaccinations. Family history, non-contributory. Social history, attends 2nd grade, no recent travels or sick contacts. Physical examination, general, well-nourished and alert in mild distress due to pain. Vital signs, BP 110, 65 millimeter HR 82 BPM, RR 20 min, temp 98.6 degrees, weight within the 50th percentile for age. Skin, symmetrically distributed palpable purpura on the buttocks and both lower extremities. No blisters or necrosis. Abdomen, soft, non-distended with tenderness in the periumbilical region. No rebound or guarding. Joints, no swelling or tenderness noted in the ankles or knees. Cardiovascular, respiratory, normal examination, diagnostic tests, urinalysis, trace proteinuria, and microscopic hematuria. CBC, normal WBC, 812.3 grams per day, platelets 250,000 per microliter. ESR-CRP, mildly elevated. Stool guaiac test, negative. F assessment. The clinical presentation is highly suggestive of IgA vasculitis, Henoch-Schönlein purpura, given the palpable purpura, abdominal pain, and recent URI. The normal platelet count helps differentiate this from other causes of purpura. Management plan. 1. Supportive care. Ensure adequate hydration and rest. Prescribe acetaminophen for pain. Avoid NSAIDs given the gastrointestinal symptoms. 2. Symptom monitoring. Instruct parents to monitor for worsening abdominal pain, any changes in the rash, or signs of renal involvement. 3. Follow-up. Schedule a follow-up visit in 1 week to reevaluate symptoms and renal function. Plan for monthly urinalysis for the next 6 months to monitor for IgA nephritis. 4. Patient and family education. Educate about the nature of IgA, its usual self-limited course, and symptoms that warrant immediate medical attention, such as severe abdominal pain, blood in the stool, or decreased urine output. Discussion points for the specialist team. The case highlights the classic presentation of IgA in a pediatric patient and underscores the importance of recognizing this condition to initiate appropriate supportive care and monitoring. Discuss the indications for systemic glucocorticoids in IgA, particularly in the context of significant GI involvement or renal disease. Review the latest guidelines on the management of IgA nephritis, including when to consider immunosuppressive therapy. Hemolytic-uremic syndrome, HUS in pediatrics, a specialist's guide. Epidemiology, predominantly affects children under 5 years of age, represents a significant cause of acute kidney injury in this demographic. Etiology, primarily linked to enterohemorrhagic E. coli, EHEC 0157H7 infections, commonly associated with ingestion of undercooked meat or contaminated produce. A typical HUS involves complement system dysregulation, less common but with a more severe course. Pathophysiology, toxin-mediated endothelial damage leads to microthrombi formation in small vessels, particularly in the kidneys, resulting in a triad of microangiopathic hemolytic anemia, thrombocytopenia, acute kidney injury. Clinical features, typically follows a gastrointestinal prodrome of bloody diarrhea. Presents with the characteristic triad, along with possible neurological symptoms due to CNS involvement and GI complications such as severe abdominal pain and intussusception. Diagnostic workup, laboratory tests, hemolytic anemia markers, low haptoglobin, elevated LDH, schistocytes on peripheral smear, thrombocytopenia, elevated BUN, and creatinine. Urinalysis, hematuria and proteinuria indicating renal involvement. Management, supportive care, fluid management, correction of electrolytes, and blood pressure control. Avoidance of antibiotics and antimotility agents in EHSE-associated cases. Renal support, dialysis in cases of significant AKI. Plasma exchange, considered in refractory cases or specific indications like neurological involvement. Eculizumab, beneficial in cases of AHUS. Medications, anti-epileptic drugs for seizure management such as diazepam or phenytoin. Antihypertensives, amlodipine for blood pressure management. RBC transfusions for severe anemia while being cautious of fluid overload. Complications, risk of chronic kidney disease, hypertension, CNS complications, and gastrointestinal issues such as intussusception or bowel necrosis. Prognosis, generally favorable with prompt and appropriate management, but long-term renal sequelae are a concern, especially in severe cases or AHUS. Follow-up, essential for monitoring renal function and early detection of chronic kidney complications. Specialists note, educate families on the importance of recognizing early symptoms and seeking prompt medical attention, especially following a gastrointestinal illness in children. Advocate for preventive measures like proper food handling and hygiene to reduce the risk of ESHEC infections. Clinical case, pediatric hemolytic-uremic syndrome, HUS. Patient information, age 3 years, gender, female. Presenting complaint, bloody diarrhea, decreased urine output, and lethargy. History of present illness. The child developed bloody diarrhea 5 days ago, which was initially thought to be gastroenteritis. Over the past 2 days, she has become increasingly lethargic with significantly reduced urine output. This lets the parents deny any recent use of antibiotics. Medical history, unremarkable, fully vaccinated for age. Family history, non-contributory. Social history, recently attended a birthday party where undercooked hamburgers were served. Physical examination, general irritable, pale child. Vital signs, BP 95, 60 mm Hz, HR 120 BPM, RR 30 min, temp 37.5 is 99.5 Fahrenheit. Skin, petechiae on lower limbs, no rashes. Cardiovascular respiratory, normal S1 and S2, no murmurs, clear lungs. Abdomen, soft, non-distended, diffuse mild tenderness without rebound or guarding. Neurological, lethargic but arousable, no focal deficits. Diagnostic tests, CBC, HB 7.5 gram per daily, platelets 45,000 regulated, WBC 12,000 begimeter. Peripheral smear, schistocytes present, bun creatinine elevated at 36 mg daily, 1.9 mg. Urinalysis, hematuria, proteinuria. Stool culture, assessment. The clinical presentation and laboratory findings are suggestive of HUS, likely secondary to an infection with enterohemorrhagic E. coli. IgA, given the history of bloody diarrhea following consumption of undercooked hamburgers. Management plan. 1. Supportive care. Admit to the pediatric unit for close monitoring. Initiate I-4 fluid resuscitation carefully to manage dehydration while avoiding fluid overload. Electrolyte management. Monitor and correct abnormalities as needed. 2. Renal support. Nephrology consultation for potential dialysis given AKI. 3. Hematological management. Monitor hemoglobin and platelets. Prepare for possible transfusion if hemoglobin drops further or if the child shows signs of significant bleeding. 4. Avoidance of specific medications. Avoid antibiotics and antimotility agents to reduce the risk of worsening the condition. 5. Nutritional support. Ensure adequate nutrition through parenteral or enteral routes depending on the child's condition. 6. Education and monitoring. Educate parents about the condition, the importance of close monitoring, and when to seek immediate medical attention. Schedule follow-up appointments for ongoing assessment of renal function and overall recovery. Discussion points for specialist team. Review the indications and timing for initiating dialysis in pediatric HUS patients. Discuss the role of plasma exchange and eculizumab in atypical HUS and severe cases with neurological involvement. Evaluate long-term monitoring strategies for renal function and potential sequelae in children who recover from HUS.